An energetic welcome to everyone joining us today for the first SCRN interactive case discussion in 2024. We are very excited that you have carved out time in your busy schedules to join us in these informal interactive case discussion series, and we hope to see you in one of our many events in 2024. The SCRN Interactive Case Discussion Series are quarterly online events that are free of charge and accessible to all that are interested in robotics. SCRN fellows and board members will present their interesting robotic cases, followed by informal discussions. These online SCRN events contribute to expanding the platform of sharing knowledge on the use of robotics in the medical field. Please keep your videos switched off and your microphone muted during presentations. During the discussions for the best interaction, we kindly ask you to switch on your camera. Should you wish to ask a question or your observations, please raise your hand virtually first. Our moderators will mention your name in order for you to switch on your microphone. Please note that making screen captures and recordings are not permitted. Video material will be made available after this event on the SCRN Training Video Services page of our website. In case you are following this interactive case discussion and feel inspired to present yourself, please send an email to contact@scrn.eu. We are happy to connect you to an SCRN board member to prepare your presentation. Additionally, all case reports presented in interactive case discussions are automatically published in the JFIB EP robotics section. Today's interactive case discussion has been prepared by SCRN board members and chairs of this event, Dr. Pekka Raatikainen from HUS Hospital Helsinki, Finland, and Dr. Pedram Kazemian from the Deborah Heart and Lung Center in Browns Mills, USA. Both are very active SCRN board members involved in the organization of various SCRN activities. I now kindly give the word to Dr. Pekka Raatikainen to introduce our first speaker.
Yes, hello to everybody, and it's nice to have this meeting here via the internet. So, like Maru said, I'm Pekka Raatikainen. I'm working as a head physician in the Helsinki University Hospital Heart and Lung Center. Maybe something going around there, some microphones may be open. So it's an honor for us to present the case from our hospital, and the case will be presented by Annukka Marjamaa. She's been working with us for several years. She completed a couple of years ago fellowship in electrophysiology and cardiac pacing in our institute, and now she will be giving a talk about single catheter ablation of AV nodal conduction via peripheral access in a patient with chronic atrial fibrillation and dextrocardia. I hope that we will have a nice presentation by Annukka, and then hopefully we will get lots of questions there. So Annukka, it's your turn.
Okay, thank you, Pekka, for your words. It's an honor and great pleasure to introduce this and present this case. We have a 74-year-old man who has Raatikainen syndrome. It's an autosomal recessive genetic ciliary disorder comprising triad of situs inversus, chronic sinusitis, and bronchiectasis. He also had coronary artery disease, and PCI was done a few years earlier. He had heart failure, LVF function 30 to 35%, and showing severe dyskinesia. He had type 2 diabetes, atrial fibrillation, and rectum carcinoma that had already spread lymph nodes nearby. His medication consisted of bisoprolol, sacubitril valsartan, spironolactone, and furosemide, and dapagliflozin for heart failure, and metmorphine and linagliptin for diabetes. Warfarin for used as an anticoagulation therapy, and he had also pregabalin, erostan, and salbutamol as an additional medications. And here we'll see his ECG presenting atrial fibrillation and LPP type conduction defect. You can also show the next slide, please. And then we can follow the third one. And so we proceeded on CRTP implantation in April 22, and the pacemaker team actually made a really nice job implanting the device from the right side using the axillary vein. And what they did is actually they used the flip function of the X-ray picture to reverse the dextrocardia. So basically everything looked normal, but only the hand maneuvers had to be reversed. But despite high dose of bisoprolol and digoxin, the CRT pacing level remained unsatisfactory, so we decided to proceed on the AV nodal ablation. So Sabine Ernst had already reported the usage of peripheral vascular access for ablation of SVTs using remote magnetic navigation. Here, so here are the pictures of the second patient of the report, and here you see the blocked venous access from the inferior side, and this was a VPV patient with left lateral accessory pathway, and the others were able to ablate it in retrograde fashion using the brachial artery for the ablation catheter and the vena for the diagnostic catheter. When using the peripheral access, it's necessary to use remote magnetic navigation, and also ultrasound guidance for the puncture is recommended for to avoid the vascular complications. Next, please. So we have vascular access sites for EP. For the right heart, we have the femoral vein and the internal jugular vein and the subclavian vein. And for the left heart, we have the arteries, femoral arteries, and the radial artery or the brachial artery, as in the previous report. Next, please. For the peripheral access for EP catheter, it's possible to use the antecubital fossa for catheters. You see the anatomy of the fossa, and the basilic vein is the biggest and the most superficial of the veins, and offers the most direct route to the heart. Second option is the brachial vein. It's big but rather deep, and there are also arteries and the nerves residing close by. Third option is the cephalic vein, but it's very thin and tortuous, so that's the third option for the vascular access. Next, please. And here you see some video clips of the patient. Here you see the ultrasound guided puncture of the basilic vein. You see the needle proceeding through the vein there on the right. We can go further to the next slide, I think. And next, the long guide wire is introduced through the needle, and that's followed by the 8 French sheet. And you see the long guide wire going there on the right. There's a little branch, but a little bit pulled down, and then you are able to insert that further. You can go to the next video. And then we inserted the ablation catheter. You will see it also on the right. It's going. There, and then we can follow the following slide, where we put the magnets on place. And as the patient has dextrocardia, so we basically turn the vectors to the opposite direction as usually. We can go further. And then we can start mapping. We did one ablation there where you see the red dots and the AV node conduction blocked, but it recovered very shortly. So we mark there his sign. You see a nice his sign there on the ablation catheter. So we mark that and make sure that the ablation catheter is stable and in contact with the tissue before we start the ablation. Wait for a little while so we can see that. And once the ablation is started, you see that the CRTP device goes to the asynchronous mode, which is the side effect of the magnetic field. And while we're burning, the AV node is then in the end ablated successfully. There, and then we can go to the next slide. While waiting for the ablation result to last, we did the electroanatomical map of the right atrium, and as you can see, you can really easily move around in the atrium, turning the vectors, even though you're using a peripheral access, and you can really nicely and in short time map the whole atrium, and also mark the annulus sites there in the end with the white dots. You can a little bit go further with the video. Yes. And then for the next slide, please. Please go to the next, yes. So then in the end, you will see the sheet removal, and only mechanical compression is needed. And what is really nice here on the right side is that the patient can directly stand up after the procedure. No bed rest is needed, and this can be really crucial for elderly and otherwise fragile patients. You can go to the next slide, please. And here you'll see the thoracic X-ray of the patient showing the dextrocardia and the 2-lead CRT-P device implanted on the right. And on the right, you have the mapping of the right atrium and the ablation sites. Whole procedure, the fluoroscopic time was minimal, only 2 minutes, and the whole procedure time was 45 minutes. Yes, and in addition to the usage of peripheral access, this case was also a single catheter procedure. And Cook and Schluter already reported already over 30 years ago the usage of single catheter in RF ablation of left-sided accessory pathways in patients with BPV. And they reported a really nice 88% success rate in their report. And other potential targets for single catheter ablation with RMNA are premature ventricular contractions in the normal heart, either LVOT or LVOT or Articus, and also AV nodal ablation in patients with pacemaker. And I conclude by saying that single catheter ablation is possible using peripheral vascular access if using remote magnetic navigation. I thank you for attention, and if you have questions or comments, I'm happy to answer.
Thank you, Annukka. Annukka, it was a nice presentation, even though some technical problems there. So, do we have any questions from the audience? It's a simple target for the ablation, but new route for it, and very nice for the patients because they can really walk out of the lab and there's no bed rest needed. And these patients with AV nodal ablation needing it for chronic atrial fibrillation, they're usually quite old and fragile patients. So this is really nice for the patients that no bed rest is needed after this. Any questions or comments? I can see some of the list there, but I can't see any hands up.
So maybe I start. This is Pedram.
Yeah.
Thank you very much. Great presentation. we've done also a couple of this. I mean, Lee's going to show us what was your experience with regards to catheter stability, because you're not using any sheets, right? You're going through with the catheter only. What has been your experience? Was it catheter stable? Was it difficult to ablate AV node? Was it easy? What was your?
Well, this was a second shot was successful, so in that sense, that was very straightforward, and yes.
And you used the non-irrigated, or was it irrigated catheter?
This was an irrigated catheter because at the moment we only using the irrigated catheter. So we had an irrigated catheter. Like Annukka said, it was really simple to manipulate the catheter there, and just for the purpose to showing that it's very easy to drive the catheter around the atria. We did the mapping of the whole atria after successful ablation of the AV node. So it was stable position. It was very easy to map, and it was very easy to ablate. So I really like this approach for patients like this.
My other question is that the X-ray showed patient had the X-rays were flipped, right? Or so
no, in fact, when we are using the stereotaxis, there's no need for flipping the X-ray or anything like that.
No, I know, but
using the Navigant screen, we can see the shadow of the ventricle and shadow of the atria there. And with the magnet, it's so simple. You don't have to think to rotate counterclockwise, clockwise, whatever. You just turn the vector to direction of the annulus there, and it's so simple. So we didn't even invert the picture there. It was so simple without it.
No, my question was that the device looks like it was right-sided device, or was it a left-sided device and the image was in reversed?
No, it was the right-sided device, and actually when they implanted the pacemaker team, they actually used the flip function of the X-ray just to facilitate the implantation of the device, yes.
So why did you choose the right axis on the side of the device, not the left axis? Was it because of the anatomy that it was?
I think the anatomy, yes.
Okay.
It's more straightforward, yes. You do everything in reverse, basically, when you have the dextrocardia.
Okay, gotcha. All right. And by the way, we have the chat function as well. So if anybody has questions, they can just post it there, and we'll announce the questions.
I can check if there's anything in the chat. Yeah. Only the welcome message for us.
Yeah. All right.
I think we can continue if there's no other questions there.
So thank you for this very interesting presentation and the discussion. If more questions arise, feel free to add them to the chats. I'm sure that our chairpersons, Pedram, Kazemian, and Dr. Raatikainen are most welcome to fold these in further discussions soon. Before we switch to Dr. Pedram Kazemian, I warmly recommend our participants to consider becoming an SCRN member. With your membership, you'll support innovation of robotics in the medical field, and you get pre-registration access to the SCRN meetings. So you support SCRN high-quality educational events, and you have access to the SCRN video services. This is a video platform that contains many hours of training material on robotics in EP. Visit our website to sign up today. Additionally, I would like to draw your attention to the other events that SCRN is organizing this year. In the interactive case discussion series, please mark your calendars for the 20th of April and the 20th of July. And when visiting the bigger EP trade shows, please check the programs from ERA on the 7th of April for the ERA SCRN joint session, HRS on the 17th of May for an HRS SCRN joint session, and APHRS on the 29th of September, also an APHRS SCRN joint session. Then SCRN is also proud to announce their plan to organize masterclasses on the 20th of March 2024. Dr. David Burkhardt and Professor Pedro Adragao are taking the lead in organizing a masterclass Brugada VT Day. And on the 28th of June, Dr. Rahul Doshi, Dr. Pete Weiss, and Dr. Raatikainen will take care of a masterclass RMN and site integration. So SCRN meetings we proudly announce as well. One is the German SCRN Symposium organized by Dr. Burkhard Hügel in Neuwied on the 21st and 22nd of June. And this is an in-person meeting It will be held in German, while all the other events are all in English. And with this event, SCRN is building their international cooperation with regional robotic hospitals. So while our audience pencils in these dates in their calendars, we are switching to Dr. Pedram Kazemian, whom I kindly give the word to introduce our next speaker.
So again, thank you very much for everybody joining us today, and obviously for our first presenter and Pekka. Our second presenter is Dr. Li Shu. Dr. Shu completed his cardiology training at our center, Deborah, and joined us as a electrophysiology fellow a year ago. So he's actually a year and a half ago. So he's in his final year of training, and he has an interesting case that he will share with us. Go ahead, Lee, and welcome.
Okay, so my topic is in regards to utilizing upper extremity for AV nodal ablation in patient who has permanent atrial fibrillation, kind of similar to the first case presentation. So a little bit overview about the presentation. First, I'm going to talk about the case presentation, and I'll have a brief discussion about a few details of the case, and followed by a brief conclusion at the end of the presentation. So first, case presentation, we have a 70-year-old male with past medical history, which included longstanding persistent atrial fibrillation, acid reflux syndrome, systolic heart failure with EF estimated at 35 to 40%. On the echo, he was also noted to have severe mitral stenosis as well as mitral regurgitation. Recent imaging study, he on the TTE, like I mentioned earlier, he has LVEF that was estimated 35 to 40% with diffuse LV hypokinesis. He also had a severely dilated left atrium with a volume index of approximately 101 ml to the meter square. He, as far as his mitral valve, he was noted to be moderately thickened with diastolic doming, with likely severe mitral stenosis, with a valve area that was estimated at 0.98 centimeters square, with severe mitral regurgitation. He was also noted to have severe pulmonary hypertension. Our cardiology colleague already had a 7-day Holter, which showed that he had 100% atrial fibrillation burden. His heart rate variation was between 45 beats per minute to 175 beats per minute. So he was referred to electrophysiology for his atrial fibrillation management. We discussed the patient as a team and take a look at his echo finding of severely dilated left atrium, as well as severe mitral stenosis and mitral regurgitation. And on the Holter, he also had evidence of a tachybrady syndrome with a minimum heart rate of 45 beats per minute and the maximum heart rate of 175 beats per minute. So we ultimately decide for the patient to proceed with pacemaker implantation with subsequent AV node ablation for ultimate rate control, given the patient profile. So this is his EKG prior to the procedure. So as you can see, he was in atrial fibrillation. His QRS is relatively narrow, less than 120 milliseconds in duration. So a few considerations prior to proceeding with the case. So we talk about, type of device the patient will need. Our consideration was CRTP versus left bundle area pacing optimized CRT. Given he had a relatively narrow QRS, we opted to have the patient undergo left bundle area pacing optimized CRT to try to better optimize his electrical conduction system after the AV node ablation. And the second portion of the consideration was access for his AV node ablation. As we mentioned on the TTE, patient had a pulmonary hypertension, as well as severe mitral stenosis and mitral regurgitation. So if we proceed with the traditional AV node ablation through the femoral vein, patient will require about 4 to 6 hours of bed rest. And then we didn't think that patient will be able to tolerate such prolonged bed rest. So we elected to proceed with upper extremity access for the AV node ablation. So first we obtained a brachial vein access. This is similar to the slides that was shown earlier. So we elected to go for the brachial vein, which is distal to the axillary vein and proximal to the median cubital vein. And it's between the cephalic as well as the basilic vein, as you can see here. This was our setup for the procedure. The picture on the left shows that we cleansed the patient's right upper extremity and draped with a sterile drape. And we had an ultrasound guided access. And you can see that we had a sterile probe over the ultrasound. The middle picture shows our ultrasound essentially demonstrating brachial vein on the right and the artery that was right adjacent to the brachial vein. And the last picture on the right is the setup. On the top is the patient's head, and towards the bottom is the patient's feet. As you can see that we used a short sheath, which is attached to the CAS system for navigation, and the RMT catheter is introduced through the short sheath in the right brachial vein. This is just a floor shot of the needle we use. We use a micropuncture in our center for most of our venous access. And this is a video demonstrating the brachial vein access, similar to the one demonstrated before. Once we were able to cannulate the vein with the needle, we introduced a short wire here into the brachial vein access. And over the wire, we introduced both a short sheath as well as a dilator. And the dilator later was removed, and then the short sheath is connected to the CAS system for navigation. Once the RMT catheter was introduced, we first created a right atrial geometry. Here you can see the RMT catheter in the right atrium. We first identified a border of SVC and IVC, and then we subsequently created a right atrial geometry, including the coronary sinus, as you can see, which I'll label shortly. We created as much geometry as possible because we also wanted to use this for our lead placement. The next step, we identified the HIS, create a HIS cloud in the right atrial mapping, so we could kind of have more of an anatomical reference when we're doing the AV node ablation as well as the lead placement. As you can see, we create a HIS cloud in the map. So now we'll proceed with the pacemaker implantation. So as we label here, that's the left bundle area pacing lead. We're able to connect it to our generator so you can see on the cardal system. And using the anatomical structure, geometry we created earlier in the RAO, LAL, we're able to look at the map and kind of place the lead in the right RV septum, kind of close to where we think the left bundle area was. And then this is just briefly about the CS placement. So CSR, skywire, and the CS, we did a venogram, and then the catheter is subselected in one of the branches. We also did occlusive venogram so that you could see the anatomy of the branch for which we're going to place the CS lead. And this is the final shot of the device that were implanted. So as you can see, there's a quadrupolar CS lead in the CS, and then there's a RV lead in the left bundle area. During the procedure, we pull back the RMT catheter in the SVC so it does not interfere with the lead placement. As you can see, we did not elect to proceed the atrial lead because the patient was going to be in permanent atrial fibrillation. So there is no atrial lead for that reason. Then we proceed with the AV node ablation. Like I mentioned earlier, we have already created a HIS cloud. Here, we're just adding more points for the HIS cloud so we can know where exactly the HIS area is. And then you can see here that we proceed with ablation proximal to the HIS cloud until the AV conduction was terminated. And this is the post-op EKG that we had after the AV node ablation, as well as the pacemaker implant. We were able to achieve relatively good results with the CRT and AV node, with the QRS approximated about 120 milliseconds post-operatively. So to talk about the utilization of the this technique, I want to introduce briefly about the conduction system pacing. So currently there are two types of conduction system pacing: HIS pacing and left bundle branch area pacing. And the one we elected for this patient was left bundle area pacing. During the procedure, you attach continuous 12-lead ECG, and you want to use a specialized sheath, and you want to visualize the W pattern in lead 1 with the notch on the nadir of the QRS. You also should see a tall R wave in 2, RS in lead 3, and discordant QRS. And once you're happy with the location of the sheath, you physically screw the entire lead until the notch in the V1 ascend to form an R wave. And there should be about 100 to 200 ohm of impedance drop. And as I will talk about a little bit later in the discussion portion, one of the big limitations for conduction system pacing is improper sheath to septum orientation. If the sheath is not oriented in a way that you can engage left bundle, it's very difficult to place the conduction system pacing lead. So a little bit of discussion about the case. So the utility of a performing AV node through upper extremity approach with mapping. So first, I want to talk about patient selection. So our patient had a significant valvular disease as well as pulmonary hypertension. And similar to the first case, obviously, patient will not be able to tolerate prolonged bed rest. So this is the reason why we elected to have him undergo AV node through brachial vein. So you could just hold some manual pressure afterwards, and he doesn't have to be lay flat for a prolonged time. And then secondly is about the procedural time. So I think, we decide to use this approach so we could create a right atrial mapping, and that will kind of help us place a certain type of lead to the location that we desired. And I think this was also very beneficial to create the geometry prior to lead placement. And then lastly, I'm going to talk about the challenges of this case. So bringing back to the AV node videos that we had, as you can see, once we created his cloud and we start to do the AV node ablation, we actually applied quite a bit of burn for it to achieve the kind of the AV node to kind of terminate the AV conduction. And you can see the catheter is in our case is kind of not very stable, and they had a lot of mobility during the AV node ablation. So I think that was one of the reasons why we had to apply a few more burns than we desired to achieve the termination of AV conduction. So in conclusion, I think as we discussed earlier, the upper extremity approach for AV node can be considered for a certain patient population, for those who cannot lay flat for prolonged time. If we do the right atrial mapping prior to the ablation, could be beneficial if we have to, subsequently do a device implantation for conduction system pacing. And as you can see, we also created geometry for coronary sinus. So if we could apply the same thing for LV lead placement, you could attach to the generator so that you could visualize the LV lead during placement in case of a difficult CRT placement. And the main challenge in our case was the catheter stability, but this could maybe improve if we could introduce a longer sheath during the procedure.
Thank you very much, Dr. Shu. That was a fantastic presentation. So I'll open the floor to question. We have one question from London. Jack Griffith is asking, do you visualize peripheral access as the next logical step in catheter ablation, or will it be reserved for special cases only? I'm not quite sure exactly what it is, but I'll answer what I think it is. If they mean by fluoroscopy, yes, we did fluoroscopy for making sure the catheter actually is in the right place, and because of this peripheral valves that the veins have, as you saw in both cases, sometimes the catheter doesn't go easily. You have to manipulate it a little bit to get past those valves. If by visualization means electroanatomic mapping, it may not be possible. Actually, we haven't tried that peripherally because it may be out of the grid area, so it may not take points. I'm not sure about that. But Pekka, did you want...
Pedram, I think that they're mentioning that is this going to be the next step for catheter ablation overall? That should we do cases with the peripheral access, or just to reserve it for the difficult cases? I think the major limitation here is that we need to have the remote magnetic system to be able to do these cases. So it's not going to be solution for all the cases. Simple cases are still done manually there. But I think that in specific cases, this is an excellent approach. And I don't know if Sabine is on the lines also. She's having a nice experiences with this approach there. That this is something, and if we're discussing with our colleagues doing the PCI, they don't ever go for the femoral artery anymore. They're doing only the peripheral access. So I think that this is perhaps the next step, but it's not going to be for everybody in the near future there.
I just want to ask you mentioned that one of our goals about the case that Dr. Shu just presented was also to demonstrate other things that you can potentially do when you access from the upper extremity. One was actually to visualize the pacemaker leads. You can actually do that because we've already created the geometry, and that assisted us with finding where obviously we know where the His was, and then you can do a His pacing or very close to the His in the left bundle area pacing. And in cases where CS is not accessible, as you saw that we actually mapped the CS as well, and using the same technique, you can actually put the lead in the CS as well. We had to prep the patient essentially in 2 layers. So the first was on the right arm axis, and then we covered that with a sterile sheet, and then went to the other side and implanted the pacemaker while the catheter was still in the body. So we used the map not only for ablation, but also for lead placement, which may be a potential other opportunity to be explored later on.
There was also a question in the chat about Annukka's case there, about anesthesia. I don't know if everybody's reading the chat there, but we used only local anesthesia just before ablation, giving only fentanyl there. So no general anesthesia in cases like that. That would be overkilling in a case like this, that we want to keep the patient in the table as short as possible and then take the patient up as soon as possible. So only local anesthesia. Waiting time 20 minutes, including the mapping and everything, the whole procedure time, like Annukka said, 45 minutes. This case was done in the afternoon, so the patient went home next morning. If it had been done in the morning, most likely the patient would have gone home in the afternoon.
Lee, there is a question for you. It says, did you map the CS? This is from Jarko Carbonen, asking, did you map the CS side branches to find the latest activation site before implanting the LV lead?
In this particular case, we did not map the CS side branches to find the latest activation site. We kind of just paint out the general geometry for the CS, just in case we have a difficult time engaging the CS.
Thank you. Yeah, but that's a good question. So that would be potential another benefit of having access to CS just before doing this, because it potentially is possible to put another lead in the or just look at the RV-LV activation time based on the sinus conducted beats, or pace in the RV and then look at for the latest activation in the LV. The issue is that the catheters, we didn't use long sheet, and the advancement of the RMT deep into the CS and into the branches without a supporting sheet might be technically difficult. But as you know, the company is working on developing the Pegasus wire, and that's potentially one potential way to actually put the 014 wire in different branches, and then the same way we hooked up the the pacemaker lead to the mapping system, we can potentially use the wire for mapping and measuring the latest activation site. But excellent question.
Yeah, it's a pity that the company let the CE mark go away from the wire there, because almost 10 years ago, I was implanting some CRT devices using the magnets. It was so simple to guide the guide wire. They went to every branch. You were able to pull it back, take the next branch, and it was so simple. And now there's no CE mark, and we can't use the wire at the moment. So it was really, really bad for stereotaxis that they let the CE mark going away. I don't know what's the situation in the US, but at the moment the wire is not available. Magnetic wire is not available for us to use.
I heard though they're working on it to bring it back apparently sometime this year, but I mean the company can comment on it later. All right.
I think that we still have time there. That I noticed that Jarkko Karvonen for our institute is on the line also, and you were referring for the conduction system pacing, and perhaps Jarkko can give you a little bit comment about that, because we've been using the conduction system pacing in Helsinki very actively during the last couple of years, and almost every pacemaker is now conduction system pacemaker. Perhaps Jarkko can give some comments about the conduction system pacing. So Jarkko is still there?
Yes, thank you. I'm still here. Yep, hopefully you can hear me. Yeah, that was a very nice case you presented, and it just made me think, should we use more the magnetics if these patients are to have AV nodal ablation? Because of course you don't want to risk, especially the His bundle lead. It's very close to your ablation site. Do you have any experience on ablating the His bundle paced patients for AV nodal ablation?
Yeah, with RMT or with manual catheter, you mean?
Yes.
With RMT, well, this was one case, but with manual catheter, haven't had any problem. In fact, it's very easy to do AV node ablation with His pacing, because you already know where the His is. Obviously, that's the tip of the catheter, and all you have to do is pull the catheter back a little bit more towards the atrium and a little bit lower on RIO view if you're using fluoroscopy. And there was a theoretical concern I had at the beginning, that would that affect the threshold on the His catheter, and would it dislodge it? Absolutely not. I've never seen any problem with that. So in fact, one of the easiest AV node ablation is after His pacing, because you know exactly where the His is. So okay. With the left bundle is a little bit more challenging, but the His pacing is very easy.
Yeah, maybe other comments on the left bundle branch optimized CRT. That's a nice concept. Of course, we've been doing these cases as well. How do you select your patients on how to implant only the LBP lead, or both the LV lead and the LBB lead?
So the one that have atypical left bundle, oftentimes even if we manage to get into the left bundle mid-septal area, the QRS doesn't narrow down because they have distal left bundle disease, and the posterolateral area doesn't come in. And in those ones, adding a left bundle, a CS lead will give us that little bit of a fine tuning to bring to make the QRS narrow. So we've done that. In this case, we technically did not need to do a CS lead, I think the left bundle, but because we were doing AV node ablation and we wanted to have a backup pacing, I thought it was not a bad idea to, instead of putting another lead in the RV, put that lead in the CS. Two possibilities. One is that sometimes the threshold goes up, or that goes, you lose the left bundle pacing later on, and then this way you have a backup. And if for whatever reason there is a dislodgement of one of the leads, at least we have a backup on the other one. So it's mostly for safety reasons, but I don't think clinically it was necessary, because as you saw, the QRS with the left bundle was pretty narrow. It was less than 120 milliseconds and almost the same QRS duration. One benefit of, again, doing the RMT is that we managed to actually pull the we know where the His is, so it's very easy to get to proximal branch of left bundle, and often you can get a very good QRS duration with the left, even with the left bundle, not even His pacing. Lee, did you want to add anything to that? That was my side of the stuff, but Lee was the one who was doing the case.
No, I think that's exactly so. So the left bundle, obviously, so a lot of time, the patient with the AV node ablation, you're doing ablation. In this case, we did RMT, but sometimes we do manual. You're always worried that if there's one lead, that there's you want to provide patient with a backup. And I think those atypical left bundle definitely it doesn't matter how much you optimize. The QRS is still, there's probably a little bit of room to work on with the additional CSP placement. Yeah.
Yes, I think we have pretty similar experiences, especially very large hearts if there's lots of fibrosis there, I think it's useful to use both LV leads and LVB leads. But I thank both of you. Very good and excellent cases. I really enjoyed.
Thank you. Great questions.
Thanks, Pedram. I now understand after seeing the case by Lee that what was the reason for the question was the catheter stable there. That it was so surprising that your case, the catheter was very unstable, moving around, and we didn't have any problems. It was staying there, very easy to steer it around and very easy to pinpoint the hist there. But what do you think that was the reason that we had it a completely different approach in the way that the catheter was moving a lot and not moving a lot?
Again, I don't know exactly what the reason is. I mean, we do PVI sometime in the left atrium, and we pull the sheet back all the way to the right atrium. We're able to do a straight line with good contact. In this particular case, the catheter was not as stable, and the proof was in the pudding, because it took a long time actually to be able to, relatively long time for AV node ablation to be able to get it, despite the fact that we identified the hist. And now, mind you, we did not use irrigated catheter. This is a 4 millimeter non-irrigated catheter, but that should not be a problem. I mean, they should be able to ablate the AV node without a problem. Yeah, I don't know. We did another case also, and that was similar to this, was relatively unstable. The one thing I can say is that we actually tilted the magnet. And the reason was that the right arm where the ablation catheter was going through, obviously it had, you can't push it too far towards the patient. So we have to leave a little bit of a room in that side. So the magnet was tilted with the side that we use for access being higher and the other side being lower. And I don't know if that has anything to do with that. I forgot which magnetic strength we used. This was it 0.08 or 0.1. I know sometimes when we go to 0.08, maybe that creates some degree of instability. But those are just my guesses. I don't know exactly what it was. Our plan was to use, we did find some long sheets that we can pass the ablation catheter through. And we thought maybe next time we want to try this, just also for other reasons as well, to see if we can pass a long sheet and a Terumo long sheet through the peripheral access and maybe park it somewhere in the middle of the right atrium. And this way, the base of the catheter will have a stability. Because on the current catheter, the Carto catheters that we have, the magnet only goes back so far. I know the Magic catheter, the new one they're working on, has more magnets in it and maybe gives more stability to the proximal end of the catheter. But these catheters really don't have a whole lot of proximal stability. So the distal part is controlled by magnet, but the proximal tend to flail and go down into the IVC or tricuspid valve. And that's the problem we found in both of these cases.
All right. Do we have any more questions?
There
Annukka,
is.
do you have any further comments?
I see something in chat from Dr. Adam Gus. Could you?
Yeah, so Dr. Gus, hi Adam, thanks for joining us. Adam's asking, I suspect it was the valvular disease, likely severe TR or significant TR. That is correct. So patient did have pulmonary hypertension and TR, and maybe that was the case also. Even putting a lead often difficult in RV with severe TR, it kind of spits the lead out of the ventricle. In this case, because we used bundle pacing, we had the lead in a sheet, so that was not a problem. But with the catheter, that definitely could have been one of the reasons. Great point. Yeah,
it's a nice explanation for it. Sometimes even with the manual catheter, putting the RV catheter in and it's coming out and out and out and again because of the leakage in the target valve. That's a good example. Anything else from the audience? I saw a message that Sabine couldn't join the meeting. It was a bad thing because she's having so much experience in these arm approaches, and would have been nice to hear her comments also. But there was some technical problems with her connections there.
Right. So for Annukka and Pekka, how many of these cases have you done, and what have you found to be the obstacles for doing it more of these cases in your institution?
We are just in the early phase. We are just starting this. We did this when Sabine was reporting this access there. Now we have a plan that we will do a short series of the AV nodal ablations with this approach, something like 10 patients or something like that, and then getting a little bit more experience there. I like the approach for these fragile patients that they can walk away. They don't have to have the bed rest that if they're in the heart failure and other things. It's really nice that they don't have to lie down for long periods of time. So I think we will get a little bit more experience with this. But this was nice case to start. That it's a little bit complex case and dextrocardia and everything there, but everything was so fluent and it really shows. In fact, what I've been doing in the peripheral access in the past, when I started my EP career, how long it's 20 years or more, I was putting the CS catheters always from the cubital area using the cephalic vein, because it is a superficial vein that I can use it and put the catheter inside without any fluoroscopy. So 25 years ago, I was putting all the CS catheters via the peripheral vein because I didn't have nice steerable CS catheters. You can easily put a common Josephson catheters to the coronary sinus from the above approach. I didn't want to puncture the big veins in the subclavia or jugular veins, so I was using only the cephalic vein for this. So I'm coming back to the basics now.
So I have good news. Apparently Sabine joined us. Let me see. Oh yeah. Okay, so
I can see Sabine Ernst has joined, so there were some questions for Professor Ernst because she has so much experience in this topic. Maybe Dr. Raatikainen or Dr. Kazemian can repeat some of those questions for Professor Ernst.
yeah, welcome Sabine. So we had two case presentation. Annukka and Pekka's team presented a beautiful case of dextrocardia with a AFib and AV node ablation from the side of the pacemaker on the right side peripherally. And then we did a case where a patient had both AV node ablation and pacemaker CRT, left bundle pacing, and AV node ablation in the same setting. Device was put on the left side, and then but the first we got access through the right side, the right upper extremity access, mapped the right atrium, mapped the his, and then we connected our pacing catheter to the mapping system to visualize where it was, and managed to get a left bundle area capture and CS placement, and then went back to the right side and then did the AV node ablation after that. We discussed a little bit some of the challenges, the catheter instability, and Pekka mentioned that they had actually no problem with that. We, in our experience, we had some degree of catheter ablation, so catheter instability, because we didn't use any long sheets. And we thought maybe contributing to that was the TR, the severe TR pulmonary hypertension that patient had. So tell us what your point of view is, and if you had problem with the catheter instability or access.
Yeah, so I'm so sorry that I haven't managed to sign in earlier, but I had technical issues, and I've been up with Malus back and forth, and finally it works. Here I am. So in my experience, I have not had any problems with stability, but I think if it's a pulmonary hypertension patient, that gives you quite a lot of troubles flow-wise. So that might be the explanation in your case. I typically haven't used long sheath because I just don't use them, and in the arm approach, I've not done that at all. There might be a point on doing this just because of the soft part of the catheter, and that gives you a little bit more backup. But overall, I think it's a very nice and stable way of doing it. I didn't find any difference to a femoral approach. And I started, as you did, in patients that had no other way or kind of an exclusive access from superior. And I think the beauty is really that you move from kind of a central venous approach, from a subclavian or jugular approach further out to the arms, just to protect the lungs, more or less, so the risk of pneumothorax is taken away, and size-wise, the vessels are large enough to allow for that. And if you have a good ultrasound-guided puncture technique, I think all the fears that we have for puncture access problems is actually not very relevant. So again, I apologize if I've missed it, but maybe you could tell how you've done the access itself. Was it ultrasound-guided? Did you veins, or how did you actually do it?
Yeah, we did it in ultrasound guided, and I did it same with Pedram's case or Lee's case there. That I think that it's a nice way because now we have a nice ultrasound machines there. But what I was just telling that in the past I was putting the CS catheter via the cephalic vein without any ultrasound 25 years ago. It was working well because that is so superficial vein that you can palpate it easily. It's like taking blood samples there, and these catheters are not going to stay there a long time. So I think that it's easy to use the antecubital area. We don't have to be worried about that. It's the patient will be using his or her arm, and then it's breaking down. That it's a different issue if you have a big catheters there that it has to be staying in the position for a long time. Then you'll have to go above the antecubital area there. But for ablation, it's easy to use also.
So when I started my approach, I basically copied what the PIC lines did. That's what I learned during the COVID pandemic, and those lines, as Pekka rightfully said, stay in for weeks. Typically are put in pediatric patients, and they stay for 4, 6, 8 weeks to treat them and allow bloods being taken and have a central line essentially. And the kids run around and they play with it. So I learned it from our PIC line team. I learned the puncture technique to be very kind of careful about the puncture itself. And as you say, this is not a line that stays in for long. It stays there for the duration of the ablation. And typically, you've both presented AF cases, but typically we do relatively simple procedures, at least at the moment. My long-term vision is that we do AF ablations this way, ideally with a 6 French catheter coming from a radial approach, so that we don't have to fuss around with the single vessel up in the upper arm, but to come from a very standard, nowadays 95% of coronary interventions are done from a radial approach, and I've done that now for VT, but you always have a little bit of trepidation about upgrading from a 6 to an 8 French on the radial approach. The coronary interventionists say, "Oh yeah, don't worry," but we need dedicated catheters in the long run for this kind of approach. But I think it's the way forward, and I hope that both of your patients were very grateful and had. The fact that you don't have bed rest, the fact that you can ambulate right away, it's relatively simple for the patient. And I can say my patients were all very happy with that approach.
Oh, it was the same for us. The patient was really happy to walking out from the lab. It's a pleasure for patients like this.
So Sabine, have you used bilateral access? So maybe put some diagnostic from left and.
Yes, I have. I always tell. Now we've done this ultrasound study that we haven't yet published, but we looked into what vessels do we have. We have essentially 3 veins, at least 3 veins on each arm. And I have done several times, for example, diagnostic catheter from the right and an ablation catheter from the left, or vice versa. And I tell the patient that I'll try to puncture and see if it just fits up on one side. That would be nice. But if not, they're very happy to just, at least get punctured with both arms. I prep both arms, and I just see, and what I learned is that preparation is very important. I scan. It's important that the patient hasn't starved too long, that they have plenty of fluid before, so sip until send. So they're not dried out. It's not the end of the day where everything is collapsed, and the venous filling is important. And then, sometimes it works when the patients are well filled, then it works even without a tourniquet. So then that, I've learned that in the long time, and I prep both arms. And I have an arm board like they would do for coronary intervention. And I puncture with one arm extended, and then once I've punctured, I move the arm in, remove the board, of course, align the arms next to the body, and then that's it. Very easy and easy to tolerate, to be tolerated by the patient as well. So it doesn't require a general anesthetic at all. It requires local anesthetic, and then it's I think much easier to tolerate than having a central line like a jugular or a subclavian puncture. And even that we would do normally on the ITU without any sedation, right? We would just do that with local anesthetic. But it's easier if it's just on the arms, the patient has not this kind of proximity feeling and feeling.
So you use radial, not more proximal. You can go antecubital.
I started with brachial approach for arterial approach. Brachial, I try to move more into the periphery. It's a matter of size at the moment. So my preference would be to have a radial approach, really. That would be my preference. For the simple fact that compression afterwards is not as easy. And it runs very close to the medianus nerve. And then we had temporary irritations of the median nerve, and that's not pleasant for the patient, quite frankly. It resolves, but it's not nice.
We had a nice presentation about this in Budapest when we had it at interventional cardiology from Hungary, telling us that it's very simple. That you can use big introducers in the radial area that just put the 8 French there, and that's all right. And like you said, it's so easy to compress them. The higher you are going, even in the arm, the worse it's getting to the bleeding issues there, that you have to have a nice compression there. So I think that we can go quite big seats, at least 8 French seats. It should be safe in the radial artery.
Yeah, no, I completely agree. I think that's the trick is why reinventing the wheel, right? There is a standard. There are all tools ready for compression afterwards. You have a standard even in your hospital that then carries out the observation for the patients is completely straightforward. And it's a matter of finding the right tools that we can borrow from the interventionalist to work with the catheters as we have now. And then in the next approach is to make the catheter just 1 or 2 French smaller. Nothing big. And when I talk to engineers, they tell me that it's not a big issue. And nowadays, where lesion size doesn't necessarily need a large electrode anymore. So I'm thinking actually beyond RF. I'm thinking pulse field ablation now. We can have a smaller tip.
Yeah, that's true. And what's the message also for stereotactics? Like you said, that you can put the diagnostic catheters from the other side. It would be nice to have a magnetically guided diagnostic catheters, because you can take all the corners. You can just put the magnets and steer the catheter to the heart without any problems there. Sometimes it's a little bit tricky with the side branches and things like that. When the magnetic catheter, soft catheter, which you can steer there, might be nice. Like I've been asking for a multi-pole catheter for mapping the atrial and ventricle. It might be just a 4-pole catheter, 2-pole catheter, which is steerable with the magnets, and you can get it there. Very small magnets there.
Yeah, the problem with that is, of course, it would align in all the other magnetic fields that you have later on when you map with the map catheter itself. So they would always align if they have permanent magnets on it. So that doesn't really make that much.
That's true, but I've already seen the pictures from Zurich that they've been mapping with 5 catheters, and every catheter is moving to different directions. So that's also possible with the multiple catheters.
Exactly. So I think the clue is we need to have dedicated catheters for this approach, full stop. So what I can say is that there is a multipolar catheter that I designed many years ago for a also magnetic approach, and I'll try to get that slimmer and with multiple electrodes, so that you can either get in the coronary sinus and then have proximal electrodes in the right atrium, maybe a unipolar electrode further out, or put it in the ventricles, have a nice His recording, pace from the outflow tract at the same time. So we need to design a couple of things that would make it easier. But I'm very confident that patients would really appreciate that. I think patients would vote with their feet to have that kind of an ablation procedure, rather than coming for a conventional ablation where they have to have bed rest for a couple of hours, or have a closure device that might dislodge. I've just had a terrible experience about a year ago with an elderly woman where I thought, okay, that is really a good candidate for a closure device. And of course it embolized, and I was in the hospital at 3 o'clock in the morning because the leg was wide and we had to have the vascular surgeon in. So that is, it is so simple, and it's just something that we have to, let's say, adapt. And I think, again, the magnetic system is so well designed for it, because it is steering the tip. It doesn't matter where the rest of the catheter comes from. And And I think especially for PVCs, it's very nice. For SVTs, it's very nice. AV node ablation, of course, you just need to get to the AV node. It's straightforward, and then this combined approach that Pedram's patient had, I think this is the way, having conduction system pacing, get the AV node ablated, perfect. And then this is, you can even put all your devices at the end. It's a one-stop shop for the patient.
I just want to add one case. We didn't present it obviously today, and that may also be another application of, or a case where the upper extremity approach might be useful. It was a patient who could not lay flat, and we actually already had the device. We needed to do AV node ablation, and we actually did RMT with patient at 45 degrees. So patient wasn't laying flat. Patient was actually semi-recumbent. So that did work, actually, surprisingly. I was worried that when the magnet comes in and the patient is not flat, it will come out of the field for the magnetic navigation, because you can't be too far away from the table magnet. But it did work at 45 degrees, at least it did work. We were able to move the catheter. So that may also be the case in some patient with orthopedic problems, for example, that they can't lay flat, or they're extremely short of breath, and short of intubating them, it's not possible. So maybe something that we can explore later on, and having patient in a semi. Now you can't sit them up completely, obviously, because the fluoroscopy, because the II has to be in the X-ray position, so for the magnet to be able to come in. But that's a technical issue, and maybe if we can solve that issue by having the II of the fluoroscopy outside of the field, maybe the patient can even sit up completely and have the ablation done. And that's, again, that may not be useful for majority of cases where blood pressure may be dropping, another thing, but for quick cases and for patient who can't lay flat, for example, for like AV node ablation, that may be possible.
Yeah, apologies for just being dropped out. I don't know what I did, but I went out. I think this is not a problem. I had several cases where that was the case. That patient was, especially the pulmonary hypertension patients, not very easy to fly flat completely. And they're not very happy. I had one that was so happy to be punctured only peripherally. He didn't, for the life of it, didn't want any femoral punctures. And I had a patient that was wheelchair bound and had so much contractions in the legs that he wouldn't have been able to do anything from the leg anyway. So that was another indication to have them have a superior approach. I think that are very nice patients to do. And again, my experience with the pulmonary hypertension is, even for pulmonary artery denervation, that's a very nice approach as well. We do this the same way from a superior approach with stereotaxis. I think that's a field that we need to look into. I think we can help a lot of patients here.
Yeah, I think we are running out of time, and it was great that Sabine, you were able to join at the end of the sessions there. And thanks for everybody listening for the talks, and thanks especially for Annukka and Lee for having a nice case presentation for us. And Marlo or Peter, do you have any final comments?
Yeah, well, I can only second the lively discussions. Thank you so very much for that. That was an amazing event for us. Very nice presentations. I wanted to let everybody know that the video material will be available next week on the SCRN training video platform, and the case reports will be published in the JFIP robotics section. Also, a big thank you to both speakers, Dr. Annukka Marjamaa from HUS Helsinki, Finland, and Dr. Lee Shru from Deborah Heart and Lung Center in Browns Mills, USA. A big thank you to Dr. Pekka Raatikainen and Dr. Pedram Kazemian, and also to Professor Ernst chiming in. Thank you so much for guiding this event. And then thank you very much to our audience for your time. We love to see you next time during the masterclass Brugada VT Day, led by David Burkhardt and Professor Pedro Adragao. We look forward to see you then, and we wish you a very nice continuation of your day. Thank you, and have a good evening.
Thanks for everybody. Bye-bye.